session of our new ASPC CardioCore Webinar Series. This series will present foundational lectures on key topics in preventive cardiology, and we are really thrilled to kick off this series tonight with a critically important topic, which is the role of coronary artery calcium testing in preventive cardiology. I'm Michael Shapiro. I'm the president of the American Society for Preventive Cardiology, and I'll be your host this evening. And we are grateful to have so many of you joining us for what promises to be a highly engaging and insightful session. Before we begin, I just want to cover a couple of housekeeping items to ensure that you have the best possible experience. We want this session to be as interactive as possible, so please use the Q&A chat at any time to submit your questions. We will have a dedicated time after the talk for our speaker to answer as many of your questions as possible. So let's get to the reason we're here. Tonight, we're going to explore how coronary calcium testing has truly transformed preventive cardiology. And our goal is to equip you with a deeper understanding of its role in refining cardiovascular risk assessment and how it informs more precise and effective therapeutic decisions. And to guide us through this important topic, I'm really thrilled to welcome a true authority in the field, a longtime colleague and a close personal friend, Dr. Khurram Nasir. Of course, Dr. Nasir is widely recognized as the global leader in CAC research and prevention of cardiovascular disease, and he has quite literally written the book on CAC. So I can't think of anyone better or more articulate to speak with us tonight. Dr. Nasir holds the William A. Zogby Centennial Chair in Cardiovascular Health at the Bakey Heart and Vascular Center, where he's professor of cardiology and chief of the Division of Cardiovascular Disease Prevention and Wellness at Houston Methodist. He's published hundreds of peer-reviewed papers and has lectured all around the world on coronary atherosclerosis, cardiac imaging, and prevention of cardiovascular disease. So we are very lucky to have him talking with us tonight. So without further ado, let's get started. Thank you for joining us, Khurram. The floor is yours.
Mike, thank you so much for the kind introduction and inviting me to speak in this CardioCore series for American Society of Preventive Cardiology on a topic that's very near and dear to my heart, coronary artery calcification. So among the wide range of choices, I thought maybe today, why not tell my story on the journey of Power of Zero, and thinking on how best to share this with this distinguished audience. I decided to focus on how this concept have shaped my own clinical practice. Now, as a preventive cardiologist, like many of you in the audience, I face a humbling dilemma with my every first patient encounter. What is your risk? A simple yet very critical question that will not only impact our choices, but intensities of interventions that we will decide together with our patients for them. Now, in this context, we all cannot be more grateful to the legendary Framingham Heart Study that nearly 64 years ago gave us insights for the first time on the concept of traditional cardiovascular risk factors that has built a solid foundation for deciding not only who is at risk, but also guiding subsequent preventive strategy. And as you can see, it has remained the law of the land generation after generation. However, recently we're learning that there is more to this than what meets the eye. And without going into too many arguments, as more and more risk scores are being developed based on these risk factors, the general consensus on the street is that these approaches are likely imprecise in delineating true risk. And depending upon how you shake the box with these risk ingredients, it may either under or over predict the true risk, begging the question, how can we do better for our patients? Now, in this quest with growing clarity over time that most of these risk factors, known and unknown, are likely going to lead cardiovascular complication, funneling mainly through the atherosclerosis buildup and progression, and hence raising another question where the focus should be. And in this regard, nearly 3 decades ago, Arthur Egerton, my colleague, friend, and mentor, put forward a new disruptive non-contrast CT technology that is now widely available, cheap, associated with minimal radiation, easy to perform, that detect calcified plaque as a surrogate of atherosclerosis and presence of burden, the core culprit for the future cardiovascular risk events, raising and the potential to overcome the limitations that we have relying on possibly the guesstimation approach based on modeling risk factors. Now, in this background, as someone who has been actually influenced by this early on, as I can show you, my journey started very early on as an intern, looking at the practical implication of management and decision, pivoting from the guesstimation approaches of risk factors to actually seeing the disease and treating the disease concept. And literally, as you can see, that one of the recommendations and the dilemma I had early on, that rather than initiating medical therapy decision based on the risk factors, maybe we can do it better in a better mechanism, for example, relying on subclinical atherosclerosis. However, the major issue with that advocacy, I would say now going back almost close to 20 years back, that we didn't have any meaningful data to push this agenda. Well, it didn't take too long to show that coronary artery calcium test was the most potent predictor of future cardiovascular disease, clearly adds above and beyond risk factors in a meaningful manner, with most of the data coming from the multi-ethnic study of atherosclerosis and later confirmed in many other cohorts, that it also equally predict across all races, age groups, and gender, and more importantly, a superior tool than other contenders such as ankle brachial index and carotid ultrasound testing. Now, while this by itself provides a significant value proposition alone, there is another angle to the coronary artery calcium story that may provide icing on the cake, and that is the concept of power of zero. First introduced when I was a resident at Boston Medical Center, working with my colleagues, especially Dr. Michael Blaha, who was also a cardiology fellow. We came up with these two simultaneous publications in JACC Imaging after being rejected in every major cardiology journal as a futile concept. The idea was simple, that rather than focusing on those with disease, maybe we can derive the greatest value from this test by actually focusing on the absence of disease, a group who may potentially be at such a low risk that most of them can be afforded flexibility downstream in our management choices. Now, not knowing that this will become a source of great debate and passion, but also had led to a wonderful journey. And despite the challenges and skepticism, the power of zero so far has stood the test of time because it challenges our basic assumption in preventive cardiology. And the reason why is that we came up with this score that there was a big dilemma as the guidelines were moving into broadening the number of patients who would be meeting criteria for statins. My thinking was that our stakeholders, including patients, physicians, and health system, may be looking for answers in how we can de-risk rather than increasing the risk of these individuals. Now, there are two key questions that in absence of established cardiovascular disease, who is at risk and whom would you treat? On the left side, you see a 58-year-old male with significant dyslipidemia, prediabetes, and based on the pool cohort equation, a risk where they would be recommended treatment. And on the right, someone where their lipid levels are unremarkable, non-diabetic, and their 10-year risk is less than 5%, that where they may not need treatment. Now, this is where the coronary artery calcium testing comes in highly handy. And the reason is because it helps overcome the fallacies and uncertainties that comes with traditional risk factor and biomarker approach. As eloquently highlighted in this study by Dr. Seth Martin, published in Circulation, showing that nearly half of the individuals where all their lipid abnormalities, which are the foundational atherosclerotic cardiovascular disease risk marker, have zero calcification. And in fact, In 10-year follow-up, as you can see on the right-hand side, those with the highest LDL and a calcium score of 0 had minuscule cardiovascular risk compared to those with early disease, but still the most favorable LDL. And by the way, it's not just lipids. Irrespective how you slice and dice the pie, a significant proportion of individuals in the so-called high-risk groups have a calcium score of 0, and hence candidates for potential lifelong intensive treatment. However, in reality, their risk is much lower than estimated, as you can see in a plethora of the data published so far. Furthermore, specifically targeting the guidelines across the Atlantic, we have shown that if we are going to make decision based about statin initiation based on guidelines, they're as good as a coin toss, as nearly half of them will have a calcium score of 0. Their reclassified risk will be well below where statin should be even considered by our guideline standards. And in subsequent investigations, the power of 0 concept gained further momentum by insights that there is no other test that can de-risk as well as compared to calcium score of 0, a study led by Dr. Blaha. Then from a societal perspective, it is extremely cost-effective to defer treatment in those patients versus treating all, as long as the test of the cost is less than $250. And more importantly, studies also have led rest to hopes that even treating a lot of individuals with statins who have a calcium score of 0, as you can see, may not yield any meaningful dividend. And then in this context, in the summer of 2018, with all of the data now available, I tried to make a final plea to the upcoming cholesterol guidelines author that maybe it's time to accept the power of 0. And it was extremely gratifying waking up to the headlines at American Heart Association annual meeting in 2018 on a really cold morning in November, that the guidelines have agreed to a bigger role for the coronary artery calcium testing, highlighting the substantial role these studies that I have shown you that have played over the prior 5 years, and more importantly, acknowledge the critical role of power of 0 for the first time. Now, that was extremely meaningful because it allowed the shift of the historical CAC role from a screening test to a decision aid. Whereas you can see in this logarithm that the power of 0 could guide us in supporting millions of patients by overcoming the inherent uncertainties that come into play with our risk scores. And this also snowballed down to multiple international and societal guidelines now have acknowledged this concept. And how do you use it? There are basically 3 very simple take-home messages that have been eloquently highlighted by some of the giants in cardiology. First, as Dr. Blumenthal would suggest, that if you're uncertain with the patient's risk, which we are for most of them, the power of 0 is the best tiebreaker. According to Scott Grundy, before starting statin, and now I would say for other similar treatments, think about coronary artery calcium test first to be sure, not only about our therapeutic choices, but intensities. And as you can see, according to Dr. Cromos, if you have a calcium score of 0, you can be flexible in your treatment choices. Now, that said, despite all these gains and I would say approvals, still in social media, we continue to face a small yet vocal contrarian and lipid-centric minority that are challenged when coming to terms with 3 decades of coronary artery calcium research. They think that the power of 0 is misleading because few will still have events, and coronary artery calcium, unlike diamonds, the power of 0 is not forever. Flexible treatment on shared decision-making with power of 0 may be something similar to asking people not to wear seatbelts. And I would say the best one comes from Dr. David Brown, who's made a huge fan following by suggesting nothing works, equating power of 0 to Coke Zero, a good slogan for terrible product. By the way, I'm a big fan of Coke Zero. At the same time, I would say I would be the first one to acknowledge that clearly there are some questions that are unanswered. And as a result, many have drawn red lines that should not be crossed. Now, let me walk you through some of them. For example, some of my good friends and colleagues across the street in Houston have suggested that paradoxically, flexible treatment in younger individuals with the calcium score of 0 in the longer term may lead to much more events. So possibly more harm than benefit. Now, that's a true concern, but the question is it true? I would say not anymore, because recently we have shown that the calcium score of 0, when applied to a relatively younger population and in an extended follow-up all the way up to 17 and a half years, overall, less than 3% events per 10 years of these individuals had for a major cardiovascular event. In perspective, if you refer to the cardiovascular risk factor guidelines, we are suggested not to even think about statins if the risk is less than 5%. And more importantly, when you look at across some of the major risk factors, there are no differences noted with almost any major risk factor, especially dyslipidemia, even with an elevated lipoprotein A, suggesting that we can be reassured with the long-term risk, even among those who may have an estimated higher lifetime risk. Now, also remember that like any other test, this is not once and a done forget one. Actually, there are new insights that for majority of these individuals, an actual warranty of period could be 5 years, where you can repeat and refine management goals. A little earlier in our practice, if you're high risk, such as with diabetes, family history, severe dyslipidemia, or elevated lipoprotein A. Now, second, if you look at both the US and the European guidelines, coronary artery calcium test is recommended against for treatment decisions in diabetes due to uncertainty whether that it would add to any meaningful risk stratification. However, subsequent MESA studies have shown significant risk classification across diabetics with the coronary artery calcium study, as shown in this study from Dr. Malik in JAMA Cardiology. The power of 0 also applies in this group. And more importantly, now the NLA guidelines based on this and other data have recommended up titration of intensity, treatment intensity based on higher scores seen on coronary artery calcium testing. Beyond that, a major dilemma in the 2018-19 guidelines were the introduction of the risk enhancers, a set of 10 to 13 risk factors, where if you're uncertain, they should be considered first rather than coronary artery calcium testing. And the question really what we try to ask in this study, whether is this even applicable? And as you can see in this study, that in absence of coronary artery calcium score, even among individuals who were candidates for therapy, that means with the PCE of 7.5%, most of them did not increase the risk to a point where they would even meet criteria for treatment. And on the right side, almost individuals with 3 risk-enhancing factors. You may have an elevated CRP, elevated lipoprotein A, maybe a family history of cardiovascular disease. There is still a 40% chance that you may have a coronary artery calcium score of 0. And in that setting, your 10-year risk is still almost less than 5%. So clearly, I think that it's time to end the debate where coronary artery calcium versus biomarkers, where one may give an idea of what your risk could be, whereas on the other, where it tells you what is your actual risk. It needs to end, because in the end, the definition of insanity is doing the same thing over and over again and expecting different results. With risk factors, we will never approach that level of precision. And as a result, I would say, let's focus where the money is. And rather than starting with risk enhancing factors, your best yield would come from a simple, less than $100 coronary artery calcium testing. Now, beyond this, of course, what about those with severe hyperlipidemia, or I would say familial hypercholesterolemia? And the question really is pushing the envelope even further in those with genetically confirmed FH who are exposed to significantly elevated LDL since birth. The question is, are they the same? Can you expect them to have a coronary calcium score of 0 in middle age despite maybe 10K years of LDL exposure in their lifetime? But when we first started looking, we were really surprised to find that among the handful of studies that have reported overall and aggregated 45% of them with the power of 0. It was pretty mind-blowing. But what does it mean? Mustering up the courage, we ask whether it was safe. Of course, in an environment of limited data, kudos to our colleague, Dr. Raul Santos, who was the first to report in a small cohort of 206 patients with a mean age of 45 and baseline LDL of 216. You could see almost half of them had the calcium score of 0. And all of them were treated on statins and non-statins, but not PCSK9, with still LDLs in 170s and 180s, and they were followed for nearly 4 years. And overall, you can see pretty high event rates of 7% when they followed up for 10 years and a median and 5. But in this population, with the calcium score of 0, we didn't find any events. All happened and with a very high rate in those who had especially high calcium scores, which was not unexpected to me at least. But at least the issue was that study was small and also a smaller follow-up. So I'm extremely grateful to Professor Gall, who merged the France and Spain heterozygous FH registry, and now within 1,500 patients, you can see nearly 7 times higher numbers who had a calcium score of 0, presented their outcome data. The mean age was 49. Their baseline LDL levels was slightly lower as better treated, followed for 3 years. Still 41% had a calcium score of 0. And when you look on the right, the event rates in these group were pretty much similar to our other group. Now, again, in this population, as you can see, that the event rate was just a minimal of 0.1% with 3 patient events happening. By the way, this is much lower event rate that you will see in the Jupiter trial treated group, which was around 0.77%. Now, the question is this reassuring? Just a year and a half ago was published a data from Japan, which I would say is one of the longest follow-up with the coronary artery calcium score in a genetically confirmed population, nearly 3 times the size of what we have reported. 13-year median follow-up, almost 4 times more than what we have seen, but we see almost similar prevalence of coronary artery calcium score and with their baseline LDLs. And as you can see on the right, clearly this individual's 10-year risk or more is even less than 1%. So now moving ahead, the question is, this finding has implications for selecting not the right therapies for the right patient. For example, with severe hyperlipidemia and on FH, when we combine data from 4 cohorts, we should have seen that substantial amount of those with the calcium score of 0, depending upon which criteria you're using for their severe hyperlipidemia, they had a much lower risk than anticipated. And as a result, the number needed to treat to prevent one event with the calcium score of 0 is still very high, and those whereas are much better if you target those individuals with the calcium score more than 100, which is now becoming synonymous as someone with the cardiovascular disease equivalent group. Now, looking into the future, these findings in FH has also practical implications. There is a growing consensus by leading international FH collaborators that yes, while we should continue to maximize statins and possibly Zetia, irrespective of your atherosclerosis burden, the power of zero can guide allocation of the more expensive and not easy accessible advanced lipid-lowering therapies and should be possibly reserved for those with the early signs of atherosclerotic disease. Now, in addition to the practical application, the one space I'm also very excited about this is the potential role in unlocking the mysteries of resilience in the foundational human atherosclerosis model, that is those with FH. Now, with direct evidence of, I would say, the undeniable anomaly, those presumed at the highest risk with a calcium score of 0, and eventually guarded from an assumed complication, I think it's introducing a model drift and crisis in the normal science phase, forcing us to think what we believe and understand. And I think Dr. Lascalzo has given us a path forward now where we have a great opportunity where some of our team members are coming to focus on this genetic superheroes with the power of zero and asking the question, what protects them? Leveraging the growing capacity in omics, exposomes, and big data, wearables, and other tools, potentially catering to the next phase of discoveries and trying to figure out healthy aging and resilience, something that many of us are interested in working on. The next area is more that beyond advanced lipid therapies and basic lipid therapies is how do we think about its role in other elements? And studies have suggested whether it's aspirin, severe hypertriglyceridemia, individuals needing the reduced clinical trials, or even GLP-1s, those with the calcium score of 0 are least likely to derive any cardiovascular benefit, and those with the calcium score more than 100 and 300 are going to develop the greatest benefit. And in this context, I couldn't agree to support my dear friend Michael's notion that in 2025, I think so it is not only financially unwise, but also not providing the best care to our patients if these decisions are made in isolation without knowing your coronary artery calcium score. Now, the next step is also, as more advanced therapies are likely going to be percolated beyond those with established disease, such as the GLP-1s, the SGLT2s, and even PCSK9 inhibitors, a big challenge is going to how to design studies in the primary prevention ecosystem to assess their efficacy, effectiveness, cost effectiveness. And I think so the secret sauce of designing the future clinical trials for these advanced therapies in primary prevention will be by excluding those with the calcium score of 0 and focusing those with the highest burden, such as a calcium score more than 100, which are considered cardiovascular disease risk equivalent. Otherwise, these studies will be extremely costly, less effective, and even the information that will be derived may not support a population health approach. At the same time, beyond what coronary artery calcium studies have done so far, we have to start looking into the future and to the parallel advancement with what I would say contrast-enhanced CT angiograms, which, as you can see, provide detailed insights on not only plaque burden and architect, especially the non-calcified plaque, but potentially high-risk plaques. That has truly intrigued our interest that where there could be a life beyond coronary artery calcium and the power of 0. And I feel blessed to have led one of the efforts of building up such a population cohort in US, the Miami Heart Study, that had shown huge diversity in the presentation of coronary plaque subtypes in a traditionally lower risk population. And even about 15% of those with the calcium score of 0 show signs of non-calcified plaque. Furthermore, we have an ongoing study in Pakistan that my colleague and PI, Dr. Bashir Hanif, presented the design, and we will be showing some premium results at the American Society of Preventive Cardiology annual meeting this year, that eventually the study will clarify whether in a younger and a high-risk South Asian population, we are witnessing a much higher non-calcified plaque burden. And so far, we have shown that particularly those with the higher risk groups, such as diabetes, elevated lipoprotein(a), severe hypercholesterolemia, and FH, have a higher probability of exclusive non-calcified plaque, even in those with the calcium score of 0. Clearly, this all suggests that in primary prevention setting, is it time to shift gears to coronary CT angiogram, as possibly we are missing a higher proportion of risk with calcium score of 0. However, I would say before we take that leap, let me ask all of us to take a deep breath, think more deeply, and ask the famous question, show me the money. The key question is that would CTA add predictive value on top of a simple non-contrast coronary artery calcium test in asymptomatic individuals? And despite the immense promise to date, both the large international confirmed registry and one from Korea have shown that the CTA findings doesn't add any predictive value for future events in asymptomatic individuals, especially coronary artery calcium score of 0, who may have about 5 to 10% individuals with exclusive yet minimal non-calcified plaque. Similarly, even in symptomatic cohorts, for example, the Scott Hart study have shown that once you account your coronary artery calcium burden, none of the major CTA features were predictive of future cardiovascular risk in 4 to 5 years follow-up. And in fact, even a larger study and a longer study from UK showed that those with a calcium score of 0, despite 5% having exclusive non-calcified plaque, had no major cardiac events, rightly questioning the need for further testing in this group. And the reason for, I would say, the lack of heightened risk with the coronary artery calcium score of 0, as shown by our Miami Heart study, is that even if you have non-calcified plaque, the burden is minuscule. Less than 1% of these individuals will have high yield risk factors such as low attenuation plaque. As a result, the yield of anything meaningful is likely very low. That said, I'm extremely bullish on the role of CTA in understanding biology and plaque changes with intervention that I truly support and advocate should be incorporated in the future clinical trials. However, I still remain on the sidelines on whether it will add any meaningful value as far as deciding what is your risk, what management do you need, and what intensity. So I would say in 2025, rather than twisting ourselves into a pretzel with the imprecise risk calculators or chasing the CT angiograms, the coronary artery calcium testing has shown us that we are better off with the simple philosophy: see disease, treat disease. If there is no meaningful disease, we can have flexible treatment goals, focus more on lifestyle interventions. For those with early atherosclerotic disease, it is time to start focusing on risk factors, especially their LDLs. For extensive disease, we should manage them as someone who already had an established atherosclerotic cardiovascular disease, such as LDL goals less than 55 to 70, maximizing statins, non-statins if goals are not met, aspirin for primary prevention, systolic blood pressure goals less than 140, early utilization of cardiometabolic therapies if they meet criteria. So I hope that you would share my views in how coronary artery calcium tested not only support our decisions in the clinical practice, but how we can truly adopt it and keep things simple. At the same time, I would say that despite all of this, if you're still a skeptic, and I leave you behind with a little humor, that in the spirit of shared decision-making and transparency, at least we can disclose to our patients that with the power of 0, you have a rare condition cause good health. Frankly, I'm not sure how to treat it. And there is really nothing wrong with you, but I think a little statin will make me feel better. So thank you so much again for the opportunity, and I truly look forward to an engaging discussion.
Well, wonderful. Thanks, Khurram, for that superb talk. I learned a lot, as always, from you, and we're fortunate now we have some time for some questions. And I would just urge all of our viewers to feel free to enter your questions into the chat box. You'll see there's a speaker tab, and right next to that, there's a question tab. So if you click on that, you'll have the opportunity to type your questions into that. While we're waiting for some questions, Khurram, I have a couple of things on my mind. You know, certain questions come up a lot when it comes to coronary calcium testing. One of the issues that's very common is you wind up doing a coronary calcium score on somebody, middle-aged individual, who may actually have multiple cardiovascular risk factors. Blood pressure is not ideal. LDL might be, somewhat elevated. Maybe some other risk factors, and maybe surprisingly, the coronary calcium score is 0. So a common question that we hear is, how should you approach risk factor management? You gave very compelling, you went through all the data on the power of 0. But what do you do about risk factors, in a 50-year-old person who, we need to keep them healthy for another 30 or 40 years? How do you approach that?
Well, that's a million or $1 trillion question, really, truly. Mike, one of the key things that has always intrigued me that our approaches have really traditionally been based mostly around population-based approaches. Now, having a conversation with an individual person, the question really is, as you've seen very clearly the data, irrespective how you slice or dice the pie with the same amount of risk factors, you're likely going to have almost 1 in 3 or 1 in half will have no disease, and irrespective their 10, 15, 20 years risk is pretty low. Whereas even if you don't have multiple risk factors, if you have significant atherosclerosis, even in a very short period term, you're higher. So I think that we need to start from what is your true accumulated risk, because that's going to dictate what needs to happen. Now, if you don't have the disease, and as you pointed out, many risk factors, now the question really boils down to utility and disutility, right? In essence, are our current approaches meeting the fact? I think so. Decisions needs to happen based on an informed choice, not from a place where I'm trying to scare my patient and saying, look, your 10-year risk is low, 15-year is risk low. This doesn't mean that you're always going to be at low risk. However, what truly we understand right now that maybe we don't have to throw the kitchen sink in, right? So, for example, a 50-year-old with LDLs of 140s and maybe pre-diabetes and systolics in the 130s and the 140s, my emphasis would be we don't have an urgency to initiate pharmacotherapy right now. Lifestyle management is going to be critically important, and you always have an option to add on therapies. A calcium score of 0 doesn't mean no therapy. That means we have flexibility. I don't need to truly push your LDL below a 70 or a 50 or something like that. And helping them lose weight, re-emphasize the value of keeping the calcium score of 0, working on their lifestyle, thinking about accumulative risk, and then always having an option on add-on of a therapy. Now, on conversely, if they have any atherosclerosis, that's going to beget. That's where the intensification really boils down. Now, that said, wouldn't it be great that in the future we can have 1 shot a year or something like an RNAi combination where it lowers your LDL and blood pressure at the same time, or some of those combinations? Now, I don't think you need a calcium score. You should start that at age 35, once a year, 10 shots, 20 shots your lifetime, and you have maintained that. The issue is a daily pill, however cheap and safe. We have seen even in patients with established cardiovascular disease, we can't get them on board. So I think so it gets a little bit more complex. So, and hence that's why individualized risk assessment and then having a more informed discussion around it is really the way to go. And that's where I believe, and I've seen how calcium score adds significant value in those conversations.
Yeah, to piggyback on that really great reply, Khurram, one of the things that comes up is, let's say you have now this shared decision-making conversation with your patient. They have risk factors, but they have a calcium score of 0. You give them flexible options. They choose to really focus on lifestyle. One of the questions that comes up is there a role for repeat coronary calcium testing? So let's take first the instance where the baseline is a coronary calcium score of 0, and then I'll ask you about somebody who may have coronary calcium and whether there's a role for serial testing.
Absolutely. So a calcium score of 0 at age 40, 50 means you haven't accumulated, you haven't had any damage. It doesn't mean you're going to not have it. And by the way, it's very clear that if you have more risk factors, the chances, the incidence is on the higher side. And clearly, that really it's going to project more events. However, what we have seen, and all of us, and especially from MESA and other studies, on an average, about 20% to 25% are going to develop a calcium score at a mean, I would say median age of 60 if they didn't have that. Of course, the higher risk factors, more likely it's going to be early. So in general, the practice and kind of, I think so even the NLA guidelines have suggested the consensus statement, if you're low risk, than 4 to 5 years. I'm more, I would say, less conservative, 2 to 3 years, especially if you have a lipoprotein elevation, if you have a strong family history, dyslipidemia, pre-diabetes, and it tends to help. But the good news is that once you have any minimal calcification, it truly changes emphasis beyond I would say lifestyle to pharmacotherapy now based, and of course, then it all depends how much they have. So that's usually the journal rule of thumb, what we practice.
Yeah. So let's say, same patient, but now this time they actually have CAC, right? So let's say they have a CAC of 50. Let's say that you present them those options. They, work on lifestyle. They may start a statin, maybe some other preventive therapies. What is your approach to potentially repeating CAC in those patients?
So once you have any atherosclerosis, so an age factor also goes very critically there, Mike. So for example, if you have a CAC of 20, for example, in a 45-year-old, that's extremely premature. So from my perspective, and at least there is a growing consensus that I should treat them as aggressive as possible. And as you know, with the LDL goals kind of now, we are learning more. If you really drop your LDL as low as possible, trying to get below 55, that's kind of where I tend to push. I don't go with an aspirin for those patients, but definitely LDL as low as possible, systolic blood pressure less than 130, and trying to aggressively manage. Now, the question really is, so what I'm doing these days, and I've seen, at least for the younger patients, when I repeat the calcium score, there is a huge variation that may happen. So for example, a calcium score of 20, I see the repeat is going to be 60, sometimes 45, 80, all over the place. That's where the challenge is. And I would really ask our audience to be very mindful. It's not the change in the calcium score. So what happens, you have some minimal dense calcified plaque, you manage them aggressively, the same lesions, their density might have gone from 1 to 4, the area increases. As you know, the calcium score is really a product of area times density. So those lesions calcify and go up significantly, and the calcium score may go from a 50 to a 90. Now, if in other individuals, actually you're having more lesions with differential thresholds, I think, and then again, we don't have really good data and we need to investigate more, that's more of an indication of actually true progression. That means that the treatment has been suboptimal and we need to push more. I truly believe that with the advent of the CT angiograms, it gives us an amazing tool to really do time series studies with the calcium and CT and really try to correlate what a true change means and who are the patients actually where we need to repeat a calcium score.
Yeah, that's exactly where I was going to go with this question is, if CAC testing in individuals who have baseline coronary calcium, serial testing maybe not so advised, particularly for patients you put on therapy. Do you see a role at this point for coronary CTA and sort of serial CTA, imaging in individuals who you have on therapy to see if you've stabilized plaque or if you've reduced non-calcified plaque or if you've increased calcified plaque, certain plaque characteristics that might be associated with more favorable outcomes. Is that something you think is ready for prime time, or obviously there's trials that are ongoing now? Are you waiting for that data?
So first of all, I'm extremely bullish on the ability of the CTA to truly give us not only the architect, but the changes, and what an amazing tool, truly above and beyond the calcium scoring in giving us the complete picture. Now, philosophically, I struggle with that for a couple of reasons. One is, for example, and by the way, we see a lot of patients and everybody's interested around the non-calcified plaque. And one big question is that comes from the patient where there's tons of uncertainty and we all don't have a right answer. And the question is, how do I know my therapies are working? Or how do I know my management is working?
Right.
And I just take a step back and I'm saying it is all about the risk spectrum. So when was the last time a patient post MI or post stent or post cabbage we have done any imaging to track whether our therapies are working? Maybe we should be doing that. I'm not opposed to that. The question is really around tools, access, cost, value. So in a perfect world, when I didn't have to put in an IV and a CT angiogram is pretty cheap, doesn't have the radiation and access issue, I would say absolutely, why not? I would love to look at.
Mhm.
Now, is it really going to add value to what we know? That's kind of where I struggle, because from the same theme, then my question is why I'm not doing it for a patient post MI. I'm trying to look at their plaques and cabbage, and we are very satisfied as a group, as a society, as a community on saying it's all about management goals, getting your LDL as low as possible, antiplatelet. So that's where principally I'm focused on, but I'm pretty open. I think so in future we'll have to rethink a lot of the things we do right now, and it's quite likely at some point the CT angiogram may come into play, especially on some of the higher risk groups, maybe the younger groups. So a field wide open to answer these questions.
Yeah. Speaking of the younger groups, one of the participants tonight asked a question that I really like, and it's a question that I have, which is there an age that you consider too young to obtain a coronary calcium scan? And I can remember, so Khurram, we started out basically at the same time. And I remember when I first got out into practice, I was enthusiastic about coronary calcium, but I started only really offering testing to individuals who were 50 years and older. This is going back many years ago. And then over time, I started to, decrease the age, maybe 45 in men, 50 for women. Then everybody starting at 40 who I thought it was appropriate to do. And now, to be honest with you, I do selectively use coronary calcium in younger people. And there's some pretty compelling data, especially from Cardia. Young people, 35, 10% of those individuals have demonstrable coronary calcium. And so for the particularly high risk groups, you imagine very high LPLA, familial hypercholesterolemia, multiple cardiovascular risk factors, very premature ASCVD, but I still struggle with it. At what age to consider maybe too young? What are your thoughts on that?
No, absolutely. And again, my journey is almost similar as, and the reason for that journey and transition, Mike, has been because most of our decisions, or at least our thinking, has been guided by the evidence and what studies have shown clearly. And we clearly understood 50 was a great mark, then started to understand there's significant proportion of individuals, even in the cardiac population at age 40, when they did, almost about 10% have early atherosclerotic disease. And by the way, those individuals who have significant accumulative LDL exposures, the numbers goes up to 15 to 16. So we'll be presenting some of that data. So in essence, if you have higher exposure, the chances of atherosclerotic disease, or I would say meaningful atherosclerotic disease here now, because exclusive non-calcified plaque, you can see in about 5 to 10%. And we're all still struggling what it means having a streak of plaque in one segment, and should that dictate changes. But I'm with you, and age is just a number. The bar is being lowering, but meaningfully and cautiously, not indiscriminately. I would say in younger, less than 40, 30 to 40, the practice, and by the way, guided by data from Cardia and the CAC consortium and many other studies, is clearly showing that if you have multiple risk factors, especially around metabolic syndrome, FH, lipoprotein A, and even obesity, prediabetes, you need to screen almost, if you have multiple, about 1 in 3 to 1 in 4. And by the way, we are not looking for a calcium more than 100. A calcium of 2 is significant, where I truly believe that that is an amazing motivation for starting early. And these are the ones who are likely going to present with most of the premature clinical events. So I'm moving, and now going beyond 30, I don't have the data. We have cases, but I think so we should definitely try to push the envelope and try to understand, is there a role in specific groups? My gut feeling, Mike, is that the process is, even in FH patients, is almost, I've hardly seen anyone beyond age 30 having any atherosclerotic disease. Now I'm talking about US. When you go outside the US, the FH in combination with environmental risk factors, diet, and everything is a completely different thing. So within the US context, I think a 30 is a good number, especially with you have multiple risk factors in the younger.
Yeah. So one of the viewers is asking a really beautiful question here. I'd be interested in your thoughts. The question is, what is preventing CAC testing from becoming a screening test for all patients? So as we say sometimes, the mammogram of the heart, right? What is preventing that from happening?
That's multiple, I would say multiple things happening. One was clearly the guidelines had some role to play in here. So as you know, in the early 2000s, there was, rightly so, that we didn't have any evidence, or at least no studies have yet proved that calcium testing is going to give me something more meaningful information as far as the risk stratification. Preventive cardiology is really based around risk, higher risk, more aggressive management, and hence parallel efforts by Mesa and Heinz Nixdorf and many clearly in 2008 showed that there's no doubt best discriminator risk stratification doesn't matter your age, gender, race. The 2010 guidelines actually adopted it as a screening tool to identify people who have disease, so we can intensely. But parallel efforts that nobody really thought about, statins became cheap, widely available, safe. And if you treat tons of patients all across the low risk, of course, they never took into account the personal disutility and patient's perspective, that it made sense. Why do you need to screen? And then we lowered the threshold, right, of entry to the statin club, which, by the way, over predicted anyways. So I still remember it was 2013 or 14 when Phil Greenland rightly asked, CAC no more. Why do we need calcium screening when already 3/4 of the individuals are? And that was kind of like the pivot and saying, okay, fine, maybe we don't need calcium now for that. It's to help guide the decisions and allocate resources, hence the power of zero, the new guidelines moving in. But I think so it's time to move back to the screening. Because that was mainly for the middle age, 50, 60 plus. For the young, I truly believe that we need to bring in the screening mechanism. Now, of course, the guidelines getting to, if you're talking about USPTF guidelines and others, they're looking for outcomes trial.
Yes.
In the young, the problem is you may have to recruit 30, 40, 50,000 individuals, 10 years study to show that to happen. Now, there is a middle ground. I truly believe there is a middle ground for us to find that evidence to move into the screening, as done by the heart CAD study published from Australia, recently published in JAMA, that showed that screening with the calcium score, randomizing them based off calcium 0 to 100 to 300, and clearly showed that calcium guided therapy significantly reduced the progression of atherosclerotic disease, stabilization of the plaque, and many of those features. I think we need some of those studies, and FDA and the guidelines may need to move the needle completely from show me the improvement in the complication to a phase where the evidence of reducing the incidence, stabilization of the plaque should be enough, where calcium testing can truly, I personally think that if we follow that trajectory, it wouldn't be long, 5, 10 years, that we would have enough evidence to go back full circle to a screening test.
Yeah, perfect. Here's a question that I really like. Our friend JD Patel asks, could you comment on the role of coronary calcium to de-risk older patients, for instance, 75 years or older?
All
What
the
are your
time.
thoughts on that?
Absolutely. And again, as I said, age is a number. We see quite often, especially in women, that you're going to see significant individual women, about 20% plus, have a calcium score of 0. Now, for a 75-year-old, even a calcium score of 1 to 10, studies bioimage and others, even in MESA and others, have clearly shown that at least the short interval term risk is on a pretty low. Now, de-risk does not always, and then again, that's always I've emphasized. De-risk does not mean no therapy. De-risk means maybe I don't need a high dose statin. I don't need an aspirin, maybe a low dose and more shared decision making. And by the way, pill burden, patient preferences and values come into a play. I clearly know that if you have a calcium score of 5 to 10, the chances, the evidence showing you're not at a heightened risk. Allow the patient to see how they want to do. And I think so that's a huge value proposition. By the way, there is a PCORI study that Dr. Blaha is looking at, where it's saying doing the calcium testing and keeping it blinded, who were randomized to statin versus not, will give us some of more clarity in that space.
Yeah, great. So, Khurram, we have about 3 minutes left, and I really like this next question that one of the participants asks, where they basically say, is there any scenario where you would use CCTA for risk assessment? Now, I presume they mean an asymptomatic individual, so not symptomatic patients where we use CTA to rule out obstructive coronary disease. Is there any individuals who are asymptomatic for risk assessment that you currently use CTA?
Look, in an ideal world, if, as I said, cost, IV access, I would have done the CTA for everyone. Now, for most of the people, and I do use CT angiograms, by the way, and those are mainly what I would say reassurance for the patient, not for me, where a lot of individuals in the young with strong family history, maybe FH, lipoprotein A, who are on the cusp and saying, I'm not really reassured. And I disclose about 10% you may have the soft plaque, and which is minimal. And by the way, we know from studies that a calcium score of 0, even in an FH and a lipoprotein is not, but in the end, the risk is not 0. And if you truly want to go more in deep, and that will help your shared decision making, absolutely CTA, with the disclosure that most of the time it will likely not be covered by insurance. In various health systems, the cost may be a few $1,000s, but there are private radiology groups who are doing it for 500 and 700. So I can tell you a small chunk of patients do opt for that, and I'm for it, as long as patient understand it's not a burden, they're able to pay. But as I truly don't yet have seen any evidence that the added value is beyond an inch if you have a calcium score of 0.
Yeah. Well, Khurram, unfortunately, our time has come to a close. I could easily spend another hour asking you a lot of questions. Our viewers had many, many other excellent questions that I'm sorry that we weren't able to get to. Thank you so much for your time and your excellent talk and the Q&A session. This was the perfect way to kick off our ASPC CardioCore series. So thank you so much. And I would ask everybody who's participating tonight to keep in mind next month we will have our second webinar. Dr. Keith Ferdinand will be talking about the management of hypertension for prevention of cardiovascular disease. So I wish you a good night and thank you again, Khurram. Really appreciate it.
Thank you, everyone. Such a pleasure. Honor to be here. Thanks.